Time now for Health Matters. We're at Redwood Urgent Care with Lynn Szabo, PA here, and tonight's topic, or I should say today's topic, it'll be airing during the daytime, is opioids. And a whole bunch going on there. How are we going to address this?
Well, I think we should start out by saying explaining what is an opioid and why is it an issue right now. So an opioid is a type of medication that's derived from the opium poppy. And we used to kind of initially directly derive it from the flower, but then they were able to synthesize similar drugs. They affect the opioid receptors in the brain, and they help with pain control. For a long time, they were used mostly for acute pain or cancer-related pain. But in the 1990s, they started being used more for chronic pain. So the opioid receptors in the brain respond to these medications, but they're also kind of tied in not only with pain control, but pleasure receptors. So they have a high possibility of addiction for people, and that can become a problem after a while. So it kind of tells us that when we're treating acute pain, that maybe there is a role for opioids, but in chronic pain, there needs to be a more holistic approach. And we talked about that previously, but other tools need to be used in kind of addressing that opioids are not really the best thing.
Now, the more holistic approach, is that because of the problems with opioids, something that was learned in conjunction with using opioids to address chronic pain?
Chronic pain, and it's because of that really close proximity in the brain where it ties reward systems in the brain with ending pain receptors, or the pain stimulus. So the problem is that that's a real big gray zone, and sometimes you're giving medication that somebody might be taking to help with pain, but really there's a secondary reward cycle in the brain, and it can cause people maybe to take more than they should. It can cause people to take it when they don't really have a pain issue, and it can cause, in the worst case scenario, probably addiction kind of issues.
Now, is that always a worry, addiction with any level, any dosage of opioids?
Yeah, and when we were initially marketed to by pharmaceuticals in the 1990s, they intentionally tried to get providers to see opioids as useful in chronic pain because they said that a patient who was taking opioids for chronic pain would not have either psychological or physiologic addiction to it. Yeah, I see your response. You have some surprise on your face, and I remember being in the conferences and listening to that and also being surprised and not really being convinced of that. Although there were some data presented, it turned out to be actually more of a marketing ploy than real science.
They're trying to sell basically opiates without the danger, right? Using these synthesized opiates.
Absolutely. And I think actually the medical profession should have been more critical of that, and we should have done, I think, more intense science before we just kind of took that ball and ran with it. Because we started using these kind of pain medicines for chronic pain, and while it was helpful to a point, the body becomes habituated to it, and you need higher and higher doses to get the same kind of control. And I actually just think an observation in my practice is that I think sometimes it's very, very difficult to tell whether you're taking the medication to help with the pain or if you're taking the medication actually in response to a physiologic withdrawal kind of picture. And it changed the way people experience pain. So people became more sensitive to pain because the receptors in their brain, they're called mu receptors, MU receptors, became more sensitive to pain stimulus, and there really wasn't, the pain didn't really improve with anything else besides more opioids. So while it was helpful, it was probably only helpful for like 4 hours, and then you're looking for your next dose of medication.
Oh my gosh.
So it really wasn't an answer. Yeah. And then people started to increase the amount that they were taking, and over the last 4 years, deaths due to overdoses have really increased. And it's kind of a sad truth about this is we see actually two peaks in the curve for people who are overdosing. One is older people who are overdosing on prescribed medication, but one is younger people who are overdosing on street medication that they probably, well, nobody really knows 100%, but there's a possibility that they started on prescription medications and then for some reason had to kind of transition to getting their medications on the street.
Right.
So that's pretty sad. Luckily in Del Norte, we actually have fewer overdose deaths. I think the most recent statistics I have is for 2017, and I think we had 4. But we have fewer deaths than Humboldt, Curry, and in Siskiyou counties. But it's still devastating. Nationwide, the opioid epidemic is actually dropping the lifetime expectancy of people.
Wow. Two things. First off, if I remember a conversation with Jermaine Brubaker from RX Safe Del Norte, that even with the 4 deaths in Del Norte County, that per capita, that's actually higher than the state average, though?
Yeah, and actually the amount of pills that people get as far as opioids in this community, that was a big article in New York Times, I would say probably almost 15 or 20 years ago now. There were 3 hot spots in the United States in Del Norte, Trinity, and Humboldt counties where they were actually using more pills, more prescriptions than they had people in the county. And they also looked at, I guess, a little place, I'm thinking Kentucky and I'm thinking also Florida. Mm-hmm. But it kind of gave the doctors in the area a big wake-up call, and we really had to look at how we were prescribing.
Mm-hmm. And you said earlier too that there was an increase in deaths over the last 4 years, but it's over the last 4 years that you've really started to hear about the opioid crisis, really in mainstream media and things like that. So even that growing awareness hasn't done anything to stem the tide of death?
No, apparently not. And I think part of that is because there's no resources to address when somebody has a problem. Mm-hmm. And the problem too is that also kind of timed with the arrival of fentanyl, and fentanyl is pretty common on the streets. It's used commonly to cut other street drugs like cocaine, and it's also hard to detect. And so since it's 50 times more powerful than any regular opioid, so fentanyl is a synthetic opioid, it's really easy to slip into other drugs, and then people don't really understand what they're using.
Wow.
And then it becomes really, really easy to overdose.
I had no idea that fentanyl was that recent.
Yeah. I remember people using fentanyl maybe as a prescribed thing, maybe 2010. Mm-hmm. And it may have come out earlier and I just wasn't aware of it because as a PA I don't necessarily always prescribe those particular medications. But I think it became more available. They say sources from China became more available about 2010, 2015, kind of in that.
That's amazing to me that all of this is, because you see this, it's such a big issue. I mean, presidents and presidential candidates have addressed this and done it, but nothing really has stemmed the tide.
That's kind of heartbreaking. And yeah. I think the problem is that there's not really a lot of good treatments. I mean, if you think about it, for an acute overdose of opioids, there's naloxone, mm-hmm. okay? And Jermaine Brubaker has done a lot to bring it to the community as far as having it available in a nasal spray. Also, laws for people getting opioids per prescription, they can get this particular medication dispensed to them. So that's kind of showing up. And there's, I think, more around on the street. It's really quite available. Mm-hmm. I know the paramedics carry it, and I know in Humboldt County at some of the needle exchange programs, they make it available. We have it here.
And Jermaine and RX Safe Del Norte, her mission, I forget how many, I want to say it was something like 300 kits that she wanted to sort of implant around the community. And right. So I know there's one at the library that my wife right. got in there. Yeah. We've got one at KFUG. Right. But they should be scattered around all over the little
almost all scattered. She only has a few left.
Good.
But she says that she's available at RX Safe Del Norte at gmail.com, and you can go ahead and drop her an email and get a kit if you feel like you need to have mm-hmm. one available. But that helps with the acute intoxication. So, but how do you keep somebody from getting to that point? Well, there's not a lot of good choices, mm-hmm. and there's also not a lot of availability of programs up here. I'm talking about how we actually treat opioid addiction. So one thing is methadone. Methadone is a synthetic opioid. It kind of plugs those mu receptors and kind of keeps them quiet, but it doesn't really give somebody the high. And so if it's dispensed kind of in a controlled way, it can kind of turn off the cravings, decrease the withdrawal feelings, but still keep somebody really functional in their day-to-day activities. I don't know of any methadone programs here. I haven't seen any around lately, but it's not the kind of medicine I normally do. But I am aware of the buprenorphine program, and this is a partial receptor agonist. So what it does is it hits those mu receptors partially, kind of blocks them, and it competes for the opioid molecules in the brain. So people don't really have the withdrawal, but they also don't really get the high. And the good thing about it is that it can keep somebody really stable for a long period of time. It can address the pain issues. It kind of makes all other narcotics not work as well, which is good, so there isn't that drive to go get something else. But the bad thing about it is it can be crushed up and it can be injected, and that is a potentially fatal situation. So,
now, difference between naloxone and Suboxone?
Suboxone is buprenorphine. It's also called Bupers. We call it Bupers.
Okay, so that's the same thing as
that. I misspoke, yeah. So it is available through Del Norte Community Health Center, but it requires a special license to prescribe. And I was reading that we really have not enough providers that can prescribe this medication. And I know they've had some transition there, and I'm not sure who's actually even in charge of the program now. But they usually go along with, with a chronic pain group and some supportive care and some education and counseling, probably even a 12-step angle. But we need about 7 new providers to start prescribing this medication to really meet the need in Del Norte County.
Wow.
Yeah, it's kind of sad. There's definitely a gap in care. So.
Well, okay. All right. So you listed. So I know someone in the Suboxone program. I also know somebody in a methadone program, but over in Medford. So yeah, this is all around us. This isn't just something that is in the news, but it's out in our community. It's in our lives.
Yeah, the problems around us. I wish the support was more around us, because we could really use it. And I am I'm a lot concerned about people. I think the medical profession kind of charged into this maybe not with the knowledge they needed to make the best decisions. And then I think we kind of got burned out on it because there were a lot of people that were, I guess you could call it jonesing for pain meds. Some people, I think, were probably using them to try and treat pain of the soul. Some people definitely treating legitimate physical pain. And I think we managed to muck it all up and make it all worse. And now we don't really have the support for these people to get out of the cycle they're in.
Wow. I think about, that's what gets me is all of this. And I guess I sort of want to blame somebody, but it's almost like, so it seems like the industry rushed because there wasn't a lot of regulation. There's not you can get things much quickly.
It was a monetary opportunity.
Exactly. But then also the healthcare profession kind of laid down on this one, didn't they?
Completely.
What motivations were there? We all know the horror stories and the B stories on like ER and things like that, where there's some drug rep and they're bringing stuff and bribing their way in, sort of. But I mean, is that actually close to accurate, or what happened?
I don't think I think we lost our scientific mind. I think we didn't ask critical questions about it. I think that we got fed data that that were maybe financially driven and not really scientifically driven. I think we got tired of saying no to people, and so it became easy to say yes to people. I think we kind of didn't realize that the whole patient needed to be treated. I think we saw patients as fractionated, and the patient became the chronic pain quote-unquote problem, and there really wasn't the support for the entirety of the person as far as making sure that they had everything they needed to feel better. And sometimes even a diagnosis could have been helpful in that, it's hard to get the proper diagnostic imaging. It's hard to fight with insurance companies, and it became just kind of an easy solution. And I think we all feel rather horrified by that. And I think that we all we're trying to find ways that we can actually address people's problems with better solutions, data-driven solutions, diagnoses, multifaceted solutions, more supportive solutions, because I know, especially with dental problems, that people really felt kind of treated meanly. That they couldn't get care. They were in real pain. There wasn't really a great solution for them. I mean, it's really hard to tell a person that their closest dental care is at University of San Francisco Dental Clinic in San Francisco. Mm-hmm. So, it was everybody could have done better. Yeah. Everybody.
So if you're somebody, what would be your advice to somebody struggling with opioid addiction, any sort of part of this, this issue here in Delaware County? What can they do?
I think that getting a primary care provider is a really good idea, because you can't really, if you don't have a primary care provider, you're wheel spinning. I think you should get somebody that you feel comfortable with, because if you're working with somebody who you feel like isn't hearing you, then that's going to go nowhere. I think 12-step programs are really important. I think that 12 steps are actually kind of rules for living right, and I know they work better for some people than other people, but I think people should give them at least some consideration. I think there should be focus on clarifying diagnoses instead of just kind of something like chronic back pain. I think there should be some understanding of what the actual problem is. I think a focus on the whole patient, and that when we talked about the chronic pain toolbox, I think that's actually really important. Mm-hmm. And I think sometimes patients need to realize that medicine cannot give them 100% relief 100% of the time. But that if you're struggling, go to your doctor, talk to your doctor. I think if you get somebody that listens to you, there's really a lot that can be done.
Mm-hmm. Anything else you'd like to add, Lynn?
I'd just like to keep this conversation going. I think it's an important one, and I'm not sure that what I'm presenting here is necessarily all the answers. I think it's helpful that healthcare providers in the community are very aware of the problem, and I think as kind of time goes on and we have more science, we'll be able to help people more effectively. But I also think there's a humanitarian part of it, and we have to stop fractionating patients and kind of see the totality of who they are and how we can best address their problems.
Health Matters. Lynn Szabo, thank you very much. We'll see you next week.
Thanks.